HIV/AIDS, Research Faculty of Health Sciences, Simon Fraser University. Mr. Benjamin Perrin, a professor at the Peter Allard School of Law, UBC. Dr. Julian Summers, clinical psychologist and distinguished professor, Faculty of Health Sciences, Simon Fraser University. Et représentant l'Arrimage Jeunesse et
And representing Arrimage Jeunesse and Mouvement de la Relève d'Amos Région, Catherine Jutras.
All of our witnesses today are appearing by video conference. We're going to ask them to provide opening statements of 5 minutes in length in the order that they are on the notice of meeting. So we're going to start with Dr. Nosek. Welcome to the committee. You have the floor.
Thank you. Good afternoon. I'm calling in today from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. Much of my work is focused on evaluating treatment for opioid use disorders, and I'd like to share some up-to-date evidence and perspectives on this topic, focusing on opioids specifically. Broadly speaking, there are three options to choose from: outpatient pharmacological treatment, or OAT, short-term detoxification, and longer-term residential care, the latter two of which may also include pharmacological treatment. Only one of these three options are systematically reported and available for independent researchers like myself to analyze. That is OAT, including methadone, buprenorphine, slow-release oral morphine, and others, prescribed in outpatient clinics and dispensed from community-based pharmacies. As of March 2024, we had just over 24,000 people accessing some form of OAT in BC. Unfortunately, retention and treatment has declined over the past 12 years. Though it's a complex story, most fundamentally, we haven't increased our daily dosing to match the elevated tolerance of our clients who are now using fentanyl as opposed to heroin. And more recently, doctors are now having to manage benzodiazepine tapers alongside OAT. Eliminating co-payments for treatment and combining prescribed hydromorphone with OAT, as we learned serendipitously through the prescribed safer supply program, have improved OAT retention, though much more needs to be done to improve this form of treatment. Short-term detoxification treatment in and of itself is not evidence-based care, but rather a means of stabilizing and linking individuals to ongoing care after discharge. These data are held by health authorities and not systematically linked to other provincial data sets. I was involved in the project. We were able to link these data in 2017, and the outcomes for people with OUD were poor. High rates of readmission to detox or ED admission, and only about 40% of people with OUD were dispensed OAT after discharge. I believe this is the only published evidence out there on detox outcome in Canada. I urge you all to verify. Data on specialized residential treatment facilities in BC are also siloed, held either by health authorities or by private for-profit clinics. We know that we have over 3,600 publicly funded treatment beds in BC, though these are not exclusive to OUD. We know very little about the outcomes of individuals accessing this form of care in BC, either at the point of discharge or after discharge. Tracking outcomes after discharge is important because what we've found is that transitions back into community are difficult, and it's likely that we need multiple tiers of support, including housing and other social supports, once these individuals are discharged. So what do we know about outcomes for people with OUD served by residential care facilities? Two systematic reviews were published in 2019, one by Cadith and one in the journal Drug and Alcohol Dependence. Though both demonstrated some positive outcomes, few of the component studies focused on people with OUD. The outcomes were mixed for this population, and none included people using fentanyl. This leaves us with more questions than answers. We need to know the short and long-term outcomes for people who received residential care for OUD, including measurable definitions of recovery. We need to build the evidence on who benefits from these services, understand what % of that population is accessing services, and ensure that access is equitable, at least on geographic, ethnic, and economic strata. We need to know about the staffing requirements and the level of financing needed to reach our target population. Can we hit scale? Finally, we need to continuously evaluate and adapt our approach as the needs of our clients change. I want to emphasize here these are not one-size-fits-all services. Through a Health Canada SUOP-funded grant, we found perhaps the greatest unmet need was care for pregnant people with OUD. Until St. Paul's opened up a perinatal SUD ward earlier this year, there were only 13 perinatal SUD beds in BC. Now, that's not just OUD, but all forms of SUD. 12 of which were in Vancouver, and none in the north, where OUD prevalence among pregnant women is 2.7 times higher than it is in Vancouver. That's coming out of a paper that's currently under review. To be clear, no jurisdiction in North America has thus far successfully responded to the introduction of fentanyl into the illicit drug supply. Neither BC nor Alberta, the provinces with the highest prevalence of fentanyl in Canada, have done so. I'm a believer in evidence-based decision-making, a learning health system. That means learning from both our successes and our failures. For the sake of the 7 more people who will die of an overdose today, just in BC, I urge you to set aside your ideologies, political beliefs, and aspirations and focus on the true scope of this problem and the needs of these people. One of the constructive actions this committee can take is to recommend, though ideally mandate, the systematic reporting of outcomes across all forms of SUD treatment, recognizing, of course, the legal complexities of doing so. We need to learn from each other to adequately respond to this persistent and evolving crisis. I've made available to the committee each of the references made within this statement. Thank you very much.
Thank you, Dr. Nosik. Next, Benjamin Perrin from UBC. Welcome to the committee. Mr. Perrin, you have the floor.
Thank you, Mr. Chair. Greetings. My name is Benjamin Perrin. I'm a law professor at the University of British Columbia. A decade ago, I was the lead criminal justice and public safety advisor to Conservative Prime Minister Stephen Harper. I supported the tough on crime agenda, the war on drugs, but I've come to realize those views were a toxic blend of ignorance and ideology. My heart was hard, my mind was closed. So what changed? I met with people deeply impacted by this unparalleled, unregulated drug crisis. People who use drugs and the family members of those who have lost loved ones. Groups like Moms Stop the Harm, who have repeatedly asked to meet with people like Pierre Poilievre, the leader of the official opposition, yet he refuses to even listen to those courageous parents. I visited overdose prevention sites and clinics that provide regulated drugs as a substitute for those made by organized crime, places that I understand some members of this committee have refused to even visit. I read the studies and peer-reviewed evidence for myself. I interviewed police, prosecutors, defense lawyers, judges, border officials, Indigenous leaders, public health experts, nonprofits, peers, and addiction medicine physicians. And my faith in Jesus Christ opened my heart to people who are suffering in our society, the marginalized, the downtrodden, stigmatized, and outcast. And I would just remind others who share my faith, profess to, Jesus came to seek and save the lost, not to condemn, not to punish. He said, let those without sin throw the first stone. So this incredible transformation and journey really led to a complete change of heart on these issues. I now have been recommending for many years a compassionate, evidence-based approach. I'll highlight the 5 urgent needs. There are many mid or long-term recommendations as well, but I'll focus on those in the short time I have. First, naloxone, the temporary antidote to an opioid drug poisoning, needs to be widely available, and people need to be trained to respond. Naloxone saves lives. Second, we must ensure that every Canadian has access to a safe place to use substances where they can receive emergency medical support, free of fear of criminal prosecution. From January 2017 to January 2024, over 400,000 Canadians used these life-saving supervised consumption services, with staff responding to over 55,000 overdoses, and not a single person died. Over 470,000 referrals were made at these sites to health and social support. As the Supreme Court of Canada said in a unanimous ruling in 2011, supervised consumption sites save lives. Their benefits have been proven. All of the sources that I'm mentioning have been given to the committee clerk. Third, regulated substances are needed to replace the toxic, contaminated, unregulated drugs that are killing Canadians. Over 42,000 people have died in our country between 2016 and September 2023 during this crisis. Now, misinformation and lies cannot conceal the true reason for these deaths. Illicit fentanyl made by organized crime, including right here in Canada, is the primary cause. detected in 82% of postmortem toxicology reports. A regulated supply could include prescribed alternatives, compassion clubs, witnessed use for no-cost regulated alternatives, but payment required for carries, and other options. Now, those who oppose regulated alternatives condemn Canadians to risk their lives with unregulated drugs made by organized crime. Regulated alternatives save lives. Fourth, we need to address this as a public health emergency. It's not a criminal justice problem. Criminalizing people who use drugs is cruel, ineffective, and deadly. Incarcerating someone with opioid use disorder increases their risk of death by 50 times. So for many, it's equivalent to a death sentence. Fifth, Canadians need treatment and recovery options that reflect 5 key requirements: evidence-based, rapid access, publicly funded, regulated, and finally, trauma-informed and culturally appropriate. Abstinence-based treatment alone is not medically recommended. Studies, including those in the British Medical Journal, show that those who complete a 28-day detox program have an increased risk of death because this is, again, it's a chronic relapsing condition, and their tolerance goes down rapidly during periods of forced or voluntary detox, making a relapse potentially deadly. This false debate between harm reduction versus treatment is a distraction. We need both. People need to be alive to enter treatment. In closing, I agree no jurisdiction in Canada has fully implemented all of these evidence-based recommendations. And I would implore you, if your goal is to get reelected and secure power, read the polling data. If your goal is to save lives, I urge you to read the research and listen to those most deeply impacted by this crisis. Thank you.
Thank you, Mr. Perrin. Next, Dr. Summers from the Faculty of Health at Simon Fraser. Dr. Summers, welcome to the committee. You have the floor.
Thank you. I'm Dr. Julian Summers, a person in long-term recovery, a licensed clinical psychologist, and a distinguished full professor at Simon Fraser University. I began my clinical career working at BC's Riverview Hospital in 1987 and was trained in addiction research and clinical practices by Drs. Bruce Alexander and Alan Marlatt. I've directed clinical training in departments of psychology and medicine and led 3 university-based centers focused on clinical and applied research. My body of research addresses harm reduction and recovery from addictions, often concurrent with additional mental illness among youth and among people who experience homelessness and frequent involvement with our justice system. I've also led primary care and telehealth programs spanning BC, Alberta, and the North. I'm here today to testify to BC's dangerous and imbalanced approach to addiction policy that prioritizes drug liberalization and legalization and largely ignores addiction prevention and recovery. This approach has been driven by an influential group of current and former health officials whose financial interests overlap with their advocacy. As has been reported by several journalists, BC's drug policies have been shaped for many years by a network of public servants and university-based researchers who previously focused on pharmaceutical interventions for HIV/AIDS. The key players include former Provincial Health Officer Dr. Perry Kendall and the Michael Smith Foundation's scientific director, Dr. Martin Schechter, who co-created Fair Price Pharma to provide heroin. Former Deputy PHO Dr. Mark Tyndall created the MySafe Society, which dispenses opioids from vending machines. Dr. Evan Wood created a pharmaceutical company and directed the BC Centre on Substance Use, or BCCSU, which was formed from the HIV/AIDS Centre for Excellence. The current BCCSU director, Dr. Thomas Kerr, was recently involved in a scheme to disrupt and silence speakers at a conference that I spoke at. The BCCSU provides significant annual funding to the Vancouver Area Network of Drug Users, VANDU, and other allied groups. He was also involved in research for the Drug User Liberation Front's activities purchasing, testing, and selling illegal drugs. DULF and VANDU have a pending court decision versus the federal government, where they argued for a Section 56 exemption to be able to legally buy and distribute drugs, including heroin, cocaine, and meth. DULF was raided and shut down by Vancouver police last year. Reports state that Dr. Kendall met with DULF about providing them with heroin. BC's current PHO, Dr. Bonnie Henry, is a protege of Dr. Kendall's and a collaborator in these misguided actions. In her report advocating for decriminalization, she wrote, quote, as overdoses become more pervasive both domestically and worldwide, jurisdictions are looking to BC for leadership and guidance. The stage is set for the province to meet this call, end quote. The BCCSU has substantial influence on public policies that focus in a dangerous and imbalanced way on pharmaceuticals. Drugs are a relatively small component of policies and services that reduce harms associated with addiction. Furthermore, the BCCSU appears to be focused on advancing drug legalization. Dr. Kendall served as co-executive director of the BCCSU after retiring as PHO, and despite public reporting of apparent conflicts of interest, I'm not aware of any actions to investigate how our current policies may be related to incentives among those involved. My efforts to advance relevant evidence have garnered a severe backlash in my home province of BC. In 2022, I co-authored a rapid review on safe supply that highlighted the weak status of evidence, likely risks, including drug diversion, and alternative interventions that are well supported by evidence. The BCCSU responded by holding press conferences and producing an open letter accusing us of conducting low-quality research, which was a grossly inaccurate statement. They also attacked my character and have sponsored plans to disrupt events that I'm speaking at and have me removed as speaker. These are the methods of activists, not scientists. In March of 2021, I briefed BC deputy ministers on evidence related to addiction, and 1 week after the briefing, I received a letter ordering the immediate destruction of our entire database, spanning over 20 years of research and involving hundreds of thousands of British Columbians. Remarkably, the BC government subsequently lied about these actions. I continue to speak out because I have a responsibility. The suffering in some parts of our country is exacerbated rather than ameliorated by public programs. We need to redirect our actions to address addiction prevention and recovery, and I'm grateful for the opportunity to appear. Thank you.
Thank you, Dr. Summers.
Representing Arrimage Jeunesse, mouvement de la relève, Amos, Catherine Jutras. You have the floor. And good afternoon. First of all, thank you for having invited me. I'm not used to having a platform like this. I've been working in the field for over 20 years. I work with people. I was a street outreach worker for many years, so I've been near them every day. People who experience the problems we're discussing today. So I was invited to this presentation. I'm not used to this. I must apologize. I'm a worker more in the field, so I'm a little stressed, but I'll do my best. So I was invited today because I conducted research for a year and a half, starting in 2021, and I finished it in 2023. I worked in the field to document the reality of people who use substances in order to explain the human person behind the problem. We often talk about probative data and figures, but usually I get the impression we forget the human being behind all this. The whole phenomenon is a very complex one, and I wanted to highlight that. So since I had an opportunity to work near these people, I had access to their histories, I had a relationship of trust with these people, so they offered me their trust to highlight the problems, because I really do have the impression that when we're talking about studies, we never have the actual data, as long as there's so many taboos around the problem. Taboos, stigmatization are things that have been highlighted and that shut out the reality that we see, or that we may not see ourselves but see in parallel. So the study I conducted, I gave it to your clerk so that you have access to it. I say study. or research, but it's with great humility because we did it on a community level, not linked to a university. So this study, or what compelled me to do this? I went to see people where they were on the streets. I had 29 directed conversations with people who use substances, all kinds of people, homeless people, as well as even a municipal counselor who uses these substances. I talked to single parents, workers, all sorts of profiles of people who use substances. And one thing that marked me and that starts my study is that the person told me, I don't want to become a statistic. You become a number if you die of an overdose. So that really gave me the impulse to conduct this study. And what came out of this? Well, there were 29 people I talked to directly. I talked to 14 workers in different services in Abitibi-Témiscamingue. That's the region I live in. And I also reached over 100 people through different surveys. What came out of it is the complexity of this phenomenon. And I'm tempted to invite you to see this phenomenon of substance use. It can be seen as a problem, but in the field, what do we see? We see that most, or maybe many people, use substances in response to another problem. So when you're talking about complexity, what I mean is you have to see the overall picture. Why are people using that substance? It's not that the substance causes something, but it's rather why are they using this substance? Try to understand why they're using these things. And to do that, you have to listen to them. In the final analysis, the experts on this reality are the people who use. They are the ones who can tell you why. Because each individual has his or her own reasons. You have to work upstream on these problems. I see this as two spheres. We talk about prevention a lot. We talked about harm reduction, but you really have to work on both fronts in parallel because this does not meet both objectives, but in the final analysis, it's the same objective, but two different types of work have to be done. Ms. Jutras, I would ask you to conclude because there'll be many questions. We're eager to ask questions, and you'll have an opportunity to make other comments during the question period. So if you have any conclusion, we'd appreciate it. Fine. I will try to conclude, but if you have an opportunity to put questions to me, I'll be pleased to answer them. What I want to highlight in my presentation here today is that really take into account the complexity and respect the rhythm of the people involved, because often I get the impression one tries to settle a problem given a certain timeline, but the pace is very important in recovery if they desire recovery, because not all people who use substances have these problems. You have to bear that in mind too. Facilitating access too, because when it comes to harm reduction, one can do something quite simple, that is giving access to analysis of the substance so that we know what's in the stuff, because that's the problem, in my opinion. This is what increases overdoses. People don't know what they're using, and they have the effects of toxicity or contamination. So facilitating access to substance analysis would be a good step in the right direction. I'll close here, but I urge you to put questions to me. Thank you very much.
And starting with the Conservatives, Ms. Goodridge for 6 minutes, please.
Thank you, Mr. Chair, and thank you to all the witnesses for testifying here today. My questions are going to be primarily directed to Dr. Summers. Dr. Summers, you mentioned Dr. Perry Kendall. What was his role when he was a public servant with the government of British Columbia?
Perry served as our inaugural provincial health officer, our head medical health person advising the provincial government.
What about Dr. Mark Tyndall?
Mark served as Perry's deputy and overlapped in that role with Dr. Bonnie Henry, also serving as deputy provincial health officer.
All right. What about Dr. Martin Skirter?
So Marty, before our most recent disagreements, I was been on first name basis with all these individuals. So Marty worked in HIV/AIDS in the center. They all had very important roles and worked collaboratively in truly groundbreaking HIV/AIDS related work. Marty, most recently, is the scientific director of the Michael Smith Foundation, which is BC's largest health research funder, and he also has a role at the University of British Columbia.
All right. When in your opening statement, you made reference to the fact that some of them are now working for pharmaceutical companies. I think that's quite concerning, but I was wondering if you could lay that out a little bit. I know you have a lot of experience when it comes to this, and so I was just wondering if you could perhaps share with us some of where they are now.
Yeah, I mean, what I've observed is that they turned attention from HIV/AIDS to addiction as a group, and appear to have preserved the same focus on pharmaceutical interventions that made a lot of sense, of course, in relation to reducing infectious diseases, but is not a good fit for addiction. As I said in my remarks, pharmaceuticals play a relatively limited role. So it's clear now that they worked together in advancing a larger agenda to prioritize the role of pharmaceuticals. They each laid claim to various corporate methods of following through on their advocacy. And unfortunately, they also took the step of stymieing criticism and had a strong influence on shaping an overall narrative that in some cases was really inaccurate. An example being that, as was said with respect to HIV, that everyone is at risk. Well, they tried to promote that same narrative with respect to addiction, where it is simply not true. Looking at BC to give some fairly stark examples.
Sorry, we have very limited time, so I just want to summarize. Sure. So you said that top public health officials who made decisions about whether Safe Supply would go forward in British Columbia then went on to found pharmaceutical companies that would stand to benefit financially by supplying Safe Supply in British Columbia.
And elsewhere, yes.
So in your opinion, is this a conflict of interest?
I wouldn't be the first to say that there is the appearance of conflict, and I believe there is the appearance of conflict.
And it's generally accepted that the appearance of conflict is in and of itself a conflict. You just said that they wanted to benefit from Safe Supply elsewhere. Could you perhaps expand on that a little bit? Where else are they trying to expand their grasp?
Well, for instance, through the Compassion Club model and or the so-called Compassion Club model, which also harkens back to HIV/AIDS, essentially groups or networks of people that would procure drugs and make them available to others. Those are now across the country. And the vending machines that are part of Dr. Tyndall's company are in multiple provinces. And the effort to advance so-called safe supply is also had national aspirations, and of course is implemented in other provinces than BC. So the origin of this is with this group. And they had their sights on having both a national and even international impact, as Dr. Henry noted in her report on decriminalization.
So you wrote a report in 2022 that was really critical of safe supply. Could you expand on that report for us?
Well, it was only critical insofar as we did this for the Ministry of Health in Alberta. And we've done systematic reviews, rapid reviews. Rapid reviews are done as they sound very quickly on a focused question, usually before Parliament or the House. And we were given a series of linked questions. We conducted our analysis. We reported our methods. We reported the questions that we were addressing. We found, as others had found, that there was no evidence directly addressing the practice that we're referring to as safe supply. We highlighted some risks, and we highlighted some alternative interventions that have far greater track records and empirical support in reducing severe addictions. So that's what we produced.
Thank you, Dr. Summers. Thank you, Ms. Goodridge. Next, Dr. Hanley, please, for 6 minutes.
Thank you also to all the witnesses for appearing today. I want to start with Dr. Nosek. Thanks for coming. You previously submitted to this committee a presentation that was based on the risk mitigation study. And I wonder if you could, it's quite a long presentation. There are lots of interesting conclusions, but could you briefly recap that study and its findings?
At a high level, people who received risk mitigation dispensations, particularly opioids, in the week after receipt had a much lower risk of death. We saw a biological gradient in that effect. More dispensations led to a lower risk of death. That was controlling for access to OAT, so it was independent of access to OAT. We've since come out with a separate study looking at co-prescription, because often, doctors co-prescribe hydromorphone tablets alongside OAT, and we actually saw some really positive benefits in terms of improving retention and treatment.
Thank you very much. Can you see these results applying to other settings? So what are the conclusions that we could derive in terms of harm reduction and safe supply as applied to other settings? Findings?
I think this is one tool in our toolbox. I think it's one step, one part of a continuum of care. As others have mentioned, I don't think this is a debate of harm reduction versus recovery-oriented models. I think we need a full spectrum of different options. I don't, in a time where we're dealing with progressively more and more toxic and unpredictable drug supply, we need more options to deal with these challenges, not less.
Are you familiar with the research of Dr. Summers, and specifically with some of the criticism of his research quality by leading addiction experts?
I am.
For the committee?
Would you like me to comment on that?
Yes, please.
I think when the report came out, I hadn't seen it. I had only seen the review, the critique. I reviewed both the report and the critique, and I came to the same conclusions as those who wrote the critique. I thought the conclusions didn't match the underlying data. I think it was premature. At that time, myself and colleagues across the other institutions I was working with were designing the evaluation of the RMG program. And it took us time to collect that data and to report it out to the public. So I was a signatory on that critique.
Mr. Perrin, thank you for your testimony. I read your book, Overdose, written in 2020. I was going to bring it for you to sign, but I realized you were on video conference today.
Sorry about that.
But when you look, you wrote that book 4 years ago. It was during the pandemic. Has anything changed apart from, in most jurisdictions, things getting worse and the contaminated toxic drug supply getting worse and more complicated? But in terms of your overall observations, your approach, your recommendations, has anything changed since you wrote that amazing book?
The core problem remains the same. It has gotten worse, and particularly, as you alluded to here in BC, if you look at the graphs in the BC Coroner's reports, we see not only do we continue to have these persistently high levels of fentanyl, illicit fentanyl in these postmortem toxicology reports, but benzodiazepines have continued to, steadily rise and increase. And so when we're looking at reasons for why, deaths are continuing, relatively speaking, unabated, despite some measures being taken, that is something big to contend with. I think the big thing that has changed, though, since 2020, 2021, is we're in the midst of a major backlash against measures that are evidence-based that we do know save lives. So specifically, supervised consumption sites, regulated safer supply, treating people who have substance use disorder as people rather than as criminals. And so when I wrote Overdose, I actually thought, to be quite honest, that I was wasting my time on a few chapters in the book where I was arguing why we need to have supervised consumption sites, why we need to have alternatives to toxic drugs. I thought at the time I wrote it, it was so self-evident, and that's where things were going. Now we see it going completely the opposite way. So the biggest concern I have right now are the misinformation and the lies that are blocking life-saving interventions.
Thank you. And can you give an example of a lie or two that is being propagated that is preventing evidence-based policy being implemented?
Here's one that I called out. This is from Conservative MP Glenn Motz. Some of you will have seen this. This is a tweet that he put out on X on April 30th. Of this year. He wrote, quote, "Trudeau decriminalized public use of crack, heroin, and other hard drugs, resulting in a 380% increase in BC deaths." That was his quote. That's a lie. I responded to him directly and in my own post, citing the BC Coroner Service data. I wrote, "This is a lie you're spreading. There's been no such increase. In fact, the most recent data at that point was from February of 2024. Comparing February 2023 to February 2024, those months, there was actually 11% decrease in people who had died." So that's the kind of lies and misinformation we're talking about. A second example I would give you is the lie that it is a safer supply that is killing Canadians. That's a lie that has been perpetuated by the current leader of the Conservative Party, Mr. Poilievre.
Thank you, Mr. Perrin. On va procéder maintenant.
We'll now go on to the Bloc Québécois. Mr. Thériault for 6 minutes, please. Thank you, Mr. Chairman. My questions will be for Ms. Jutras. Inaudible. I'm sorry? A little lower, please. Thank you. You will restart the clock, Mr. Chair. Ms. Jutras, you don't have to blush or apologize for your tone. I think it's important that beyond the experts we've seen and beyond the toxic mix of ideology, we can find out the truth in the field, subjective truth, of course, but through your voice and your work, we can hear and listen to what these human beings have to say to us and what lessons we can draw and adjust our practices given this suffering. Now, Mr. Chairman, if Ms. Jutras allows, I'd like us, for the benefit of the committee, to have her table her qualitative study to the committee so that we can refer to it if she agrees. I'd like this to be a reference document for the committee. Yes, of course. So, you had access through the sample of people. 29 people opened up their soul and agreed to testify and trust you. Stigmatization is one of the biggest dangers that people with an addiction problem have to face. We heard about that during our trip throughout major Canadian cities. I'd like you to discuss that further, if you would. What are the harmful effects of stigmatization? How do these people talk about it? Well, I have a example, a striking example. When I looked for these witnesses who were willing to share their life story, there was a parent who said, a person I didn't know, who said, it doesn't make sense. We have to talk about this. And that parent explained that this was a single parent with 2 children. One child was very high need, and that person was incredibly afraid. I'm not saying this for nothing. This person contaminated me with the fear. I won't say whether it was a mother or a father because I don't want to identify them. I'm too afraid. But this could be representative of many parents in this situation. I don't want to identify them. I want to respect them. But in their family, this parent had police officers and other interveners. Nobody in the family knew that this person uses substances. They use 8 to 10 speed doses per day, and their goal is to be a good parent. And they say, I can't. I don't manage. I don't have the energy. I have this social pressure on me. With everything you know about social pressure to be a good parent, this person takes 8 to 10 doses of speed per day and doesn't seek out services. Why? Because they said, they'll take my children away. That's the end of my life then. So this incredible fear of asking for services, of discussing this. I could hear this person's voice shaking when talking to me. That's part of it. Cutting yourself off from all sorts of services out of fear. There's stigmatization, of course. It goes even further, really. Self-stigmatization. At some point, you integrate that discourse. I'm thinking of another person. Somebody highly involved in the community, intervener who helped many people, whose life turned around, and she was an injected drug user, and she was called garbage on the streets, and she had done so much for the community, and takes all that in. She's offered help, and she says, no, I don't deserve it. And somebody else who asked for help at some point. In my study, I talk about neuron door. There's no wrong door. There's no bad way to ask for help. This person knew about this recovery facility. but didn't know all the administrative ins and outs of it, the bureaucracy. One night came to use drugs and said, I can't anymore, and knocked on a door. It was a place she knew because friends had been, and somebody said, you can't come here. You have to go through the usual channels, through the CLSC. And that person didn't criticize the system. That person said, I don't even deserve the support by an organization that looks after this. I'm worth nothing. And she went off and used drugs. So that's what it means if you integrate that message of stigmatization. Thank you, Ms. Jutras.
Please, for 6 minutes.
Dr. Summers, maybe you can tell me a bit, addiction is obviously a chronic relapsing condition, and it takes years for people to recover. Why would you be against safer supply to replace the unregulated, toxic, poisonous street drug supply for people who relapse?
Thank you for the question. Because it's imbalanced, the broad programs internationally that have shown the greatest success dramatically reducing high-risk addiction have put the goal before themselves to ensure social reintegration. And that theme was also once active in North America. In fact, that is the format in which methadone was introduced as a practice. It was not a standalone drug administration program, but an inducement into a much more comprehensive process that ensured social reintegration. Okay. By adding drugs to and not paying attention to the necessity to support robust social reintegration, we are essentially, in many cases, providing into a system of poverty a fungible asset.
Okay, that's not the question. I think I think we all understand this is a complex issue. It requires a comprehensive, full slate of responses. So I'm trying to get an answer on that. Now, you talked about
the answer is it will make things worse.
Well, that's what your viewpoint is. I mean, the First Nations Health Authority, the BC First Nations Justice Council, the Canadian Association of Police Chiefs, Dr. Henry, who you seem to not
Canadian Association of Police Chiefs.
Hold on. I'm not done yet. And all four chief medical health officers on Vancouver Island, where I live, the chief coroner of BC, the expert task force on substance use, have all called and supported for a safer supply of substances. And I guess what I'm hearing from you is that you seem to know better than them. And now you've talked about
were any of them trained in addiction?
Well, there is many that were on the expert task force on substance use. Absolutely. And we're talking about those that are trained in addictions. And as well, you've cited conflict of interest. And you went after Dr. Perry Kendall, and he established a nonprofit called Fair Price Pharma, and also Dr. Tyndall, who also created MySafe, which is a nonprofit. I mean, can you explain? These are nonprofit pharmaceutical operators trying to create a safer supply of substances, but you've talked about them being for profit. And also, we heard about 50 esteemed experts that wrote a letter that disagreed with your paper on housing. What do you say to those experts that wrote the letter, including Dr. Nozick, who's on this panel right now?
So there are a number of allegations in your preamble. I'll focus on the question you concluded with. So we wrote a review. It did not, as Bowden suggests, veer away from discussing the facts of what we found. Other reviewers at the same time had reached the same conclusion, which was there is no evidence to support the safety or effectiveness of these practices. In fact, if you search the BCCSU's website and the materials that they're providing, you will see that exact disclaimer today. There is no evidence to support the safety or effectiveness of, and there are a variety of practices that fill in the blank, in order to reduce risks associated with fentanyl and other street drugs. So that was the main conclusion. Now, how did they assess it? They used the AmStar rating system. Bear with me. AmStar is a rating system.
You have to be very quick because I have other people I want to ask questions to.
Okay. Well, you asked, I'm answering.
Okay. I'm actually. Yeah, go ahead.
They used the AmStar rating system, which is a rating system for systematic reviews. I've published systematic reviews on substance use and mental illness over the years. It's important that they be standardized. Rapid reviews are not systematic reviews. So what you're pointing out is that 50 people signed on in an emotional reaction to a critique of a rapid review using an entirely inappropriate tool, which is basically...
Thank you. I've got a minute left. Dr. Nozick, would you like to maybe comment or give some comments on what you just heard?
You know, again, this was a review that was done very early in the stages of implementation. I would just urge the panelists to read the review, read the critique, and come to your own conclusions. I'll leave it at that.
Okay, but I'll go back to you, Dr. Nozick, and you've heard me talk about all of the different organizations, and now they're being their credibility is being undermined, saying that they're not experts in substance use. What are your thoughts on that when you hear about the long list of different qualified experts that I just talked about and their organizations that they represent?
I would argue that their credibility is very much intact.
So when you hear their credibility being attacked, and you produce peer-reviewed research, your peer-reviewed research is being undermined when you hear comments that counter what Dr. Summers said.
Yeah, you know what? I don't personally. I don't take it personally. I think it's good to have dialogue. I think it's good to have alternative positions on matters. We need to discuss. This isn't a simple issue. We had plenty of critiques on our work when it came out, and we responded thoroughly as best as we could through public presentations and tried to deal with it as scientifically as we could.
Thank you, Dr.
And I'm all
Nozick.
for debate. Yeah.
Thank you, Mr. Johns. Next, Mr. Genuis for 5 minutes, please.
Thank you, Chair. My questions will be for Dr. Summers, but I do have a quick comment for Professor Perrin. I want to say, sir, that I respect your sincerity and your conviction, and I've read your book. I do think your comments demonstrate the risk of combining good theology with bad science. I agree with you that love and compassion should define the character of our approach, including love expressed through effective dissuasion from danger and support for recovery. But as Dr. Summers has demonstrated, the NDP